Yes,
conference?
that's what I was saying.
He is there. He is going there.
Okay, I think we're live now.
Okay.
Thank you, everyone. Thank you so
Saurabh,
much.
I performed your duty.
Yeah, thank you so much. You were taking my 0
I
hours
performed your duty.
while the tech
Good morning, Saurabh.
Thank you so much. We are here again. I think there was a wonderful conversation happening for endocrinologist over here. We have a well-known endocrinologist having a special session on holistic approach to obesity management. We have Dr. Dina Shrestha. Is that right? We are honored to welcome her. She's an MD endocrinologist, senior consultant endocrinologist at Norvic International Hospital and Siddhi Polyclinic at Kathmandu in Nepal for an insightful session of obesity management, a holistic approach. She's a renowned endocrinologist and an obesity expert with extensive expertise in diabetes, thyroid disorder, metabolic health. She has have several prestigious leadership positions across South Asia Endocrinology Society, is widely been recognized for her contribution for obesity research. She's a president of SOF South Asian Obesity Forum, past president, Dean is Diabetes and Endocrinology Association of Nepal, SAFES South Asian Federation of Endocrinology Society, executive member of PCOS Society of Nepal, and Down Syndrome Society of Nepal. She's a chair for Trial Steering Committee of Co-Direct Nepal Study, founder of DRRC, International Editor Board of Asian Journal of Obesity. I think this will continue on, going on, and the presentation will.
I think that is enough. Thank you so much.
And a book of introduction.
Yeah, I think very nice. We are very honored to have her over here, and I will start the presentation.
Thank you so much. And
meanwhile, Dr. Dina, till I open the presentation, you can just give some introduction for the topic.
Yes, so I mean, it's at least in the endocrine world or in this of physicians and in South Asia now, obesity has become a problem, and everybody is addressing problem. Whether, like I think Dr. Was saying, whether you're a pathologist, whether you're a physician, whether you're a gynecologist, anybody and everybody somehow is getting into, like, we are facing the global pandemic of obesity, and that is why it is very important that we in South Asia find a way to how to manage this obesity in a very good, appropriate, person-centric and a holistic manner, right? So today's presentation there's nothing like a new things, but it's just something how I actually want to say that we put together everything and we give the patient the best management. So yes, thank you so much for those slides. So what is obesity, right? So maybe a decade ago or 2 decades ago, we were just like, this is nothing, this is just a symptom, this is not a disease, it is something that can be easily managed. But we now realize that obviously obesity is a complex chronic disease and it has a lot of health implications. Next. And we know that obesity is now actually acknowledged as a disease and a health issue across the globe. And why not, right? Like when we say, like, how do you define health? Health is a state of complete physical, mental, and social well-being. And definitely when you're obese, you don't have that. And if you put the AMA criteria for disease, right? So if you say if there's an impairment of normal functioning, of course there is. In obesity, there's appetite dysregulation, there's infertility, there's dyslipidemia. And if you say, what are the signs and symptoms? We have the increased body fat, we have the symptoms of joint pain, altered metabolism, shortness of breath, so on and so forth. And obviously what we don't like is also the harm and the morbidity, right? So we do get type 2 diabetes, cardiovascular disease, cancer, osteoporosis, like so many, which we will discuss later. Next. So when obesity has met the criteria for a disease, what is the issue now? Why is the whole world talking about it? Why are we so concerned about it? Why are there societies? Why are there so many medications? It's because the power is in the numbers. After WHO has declared the obesity as the largest global chronic health problem in adults, and now actually in obesity, we have WOF saying that our children are equally affected, and that's not a good thing. And it has replaced more traditional problems, like, you know how in South Asia first we were like, or Africa, we were like, okay, there's no nourishment, there's infectious disease, but definitely now chronic health diseases have taken over, and these NCDs. And if you really see the powers in the numbers, 39% of the world population are actually overweight if you see an BMI of 25. And we know that for South Asia, it is not 25. And almost 13% are obese if you take the obese. So there's a lot of numbers. 1 billion people actually say are overweight and obese. Next. And then it's like how we really took it that this complex disease, we actually thought was something very simple, right? You either eat more or you don't exercise. That is it, what we thought. But obviously not. Like in diabetes, we know that there are, first it was an octagon, now there's like 10 different reasons why you get diabetes. The same way in obesity, there's biological, there's genetic, there's psychological, social, medications that we give or the patients take, and the environment. All these come together and they pave the path for obesity. And there's a complex interplay. It's not as simple as, okay, eating more, exercising less, or, you know, your family is a bit obese and you have, no. There's a lot of things going on over there. Next. And being from, I always say from South Asia, we know that social culture and social economic factors obviously play an important role, right? Our culture, anybody dies, anybody is born, anything you're happy, anything you're sad, anybody loves you, it's all about eating, you know? You feed them, and you feed them. And also the social economic factors. We know that in the West, we have seen that carbs are cheaper. People who are on the lower social economic background actually tend to eat more carbs. And when you tell them, okay, you know, eat your fruits, eat your nuts, have extra virgin coconut oil, I mean, most of the people can't afford. What they can afford is probably just bread, rice, and some dal, the pulses, which are cheap and day-to-day. And that also leads to obesity. Other than that, of course, the prevalence of fast food. Anything that is, Nepal is still lucky that we don't have a lot of, we don't have McDonald's at all, and we don't have KFC, but we have our own kind of junk food. But also fast food is available, like burgers, pizza, noodles, fried rice, it's everywhere, right? And I think this is valid even for doctors, that, you know, our sleep time is getting less, whether it is because of entertainment, work, TikTok, anything, social media, we do sleep less and there's a lot of stress. We are at a social, we do have a racial and ethnic variation. Needless to say, Asians have a high risk to obesity. And of course, other lifestyle like alcohol, you know, lack of exercise is one of the reasons for our environmental factors predisposing us to obesity. Next. And then it's not easy because it's not like one gene, you know, if you map it, is like related. Okay, so let's knock out the genes. There are hundreds of genes and genetic loci that are actually associated with obesity. Next. Next, please. And these are leading to multiple complications. You know, it's not just one complication. If you grade them 1, 2, 3, 4, 5, we know that, of course, the most obvious diabetes, hypertension, cancers are related to obesity. But things like GERD, infertility, and so many, if you go on to click, you will see that more than 229 plus complications are actually related to obesity. Next, please. Thank you. Next. And then you know how sometimes we tell the patient that, you know, if you do not lose weight or if your BMI increases, you have a low quality of life. No, actually your life expectancy goes down. So that is important. It's not only that your quality of life goes bad, but also your life expectancy decreases. Next. I have a lot of slides, so I think we can go a bit faster. So why is weight loss so difficult, right? So we're like, oh, because our body is meant to resist weight loss, especially if you have strong genetics, strong biological factors, you know, and then we have these hormones, satiety hormones. The moment you eat less, your satiety hormones go down, your hunger hormones go up, your energy metabolism goes down, and of course you regain weight. Next. So we are made in a way that there's a push and pull. We have so many patients who tell us, no, I lost 3 kgs, then I put it back on the moment I had a 5-day or a 15-day gap. So definitely, like, there's a push and pull over there. Next. So all these hormones are working in a way, and that is why we see that there's, despite everybody working so hard, the next slide, that we actually have enough studies to prove that weight loss with lifestyle interventions alone actually works in the beginning, but actually fails in the long term. Not saying that we should not, but the thing is that with lifestyle, we also need behavioral therapy, we need medication, we need other interventions. Next, please. So really, we now know, of course, that the brain is one of the most powerful things. That is why the GLP analogs work so well, because they work on the hedonic input. Anything that is telling us to eat more, gives us pleasure, gives us dopamine, makes us eat more, right? So that affects our adipose tissue, our pancreas, our gut, everything. Next, please. So like the way we have the 4 pillars now in heart failure management, in kidney disease management, we can also say that in obesity management, we can have the 4 pillars. First, obviously, like we say, lifestyle is recommended. It's not like, okay, there's a failure, so you don't do it. Failure, it might be there, but it does work and you have to maintain it. And you might need other things, like you need cognitive behavior therapy. Simple things like the way we explain, sometimes when you say, you cannot do this, even with children, I cannot eat this. Oh, everybody's having a party, or, everybody's having sweets. I cannot eat this. They can be taught to say, I should not have this. This is bad for me, right? So the right approach of your mind, good behavioral therapy, behavioral modification, where you say, okay, I will eat, but I will not eat a lot. I will eat, but maybe I'll take it once a month. Slowly you change your behaviors, not just, no, you cannot eat this. Restrictive behavior, prescriptive behaviors do not work anymore. Then, of course, we are lucky that we are living in an era where we have the weight loss medications, from the old ones to the new generations. And the 4th pillar is, of course, when all this fails, we do have people who need surgical intervention, bariatric surgery. Next. So obesity should not just be, so my take on this holistic approach is actually that it should not be, because it's multifactorial, right? There's so many determinants. So it cannot be that when we give a treatment or when we're talking to a patient about obesity, we just say, okay, do this or do that. It has to keep in mind, what is the cause of obesity, right? What are the complications the person is facing? What is the obesity class and stage? And obviously the most important is, no matter how much you want the patient to lose weight, as long as the patient is not ready to lose weight, is not motivated for the change, it is very, very difficult. That is why the behavioral therapy is also important. Next. These are the next 2 slides are one of my favorite slides, that sometimes despite everything, the 4 pillars also, we are seeing patients who are obese because they can be the endocrine disruptors, the metabolic disruptors. We have to keep in mind in our background that there are these papers, these plastics, these bottled, these processed things that are packed in a way that they might have obesinogens, right? So we have to also lobby and think of how to remove these endocrine disrupting chemicals from our system, from our society. Next. Even simple things like paint, plastic, water bottles, our lunch boxes may all be packed with these EDCs and NDCs. Thank you. Okay, so then of course the conventional way has always been, okay, BMI, you check your height, you check your weight, and a lot of patients also come to us and say, what should my weight be according to my height? But these days it is, that is one of the easiest ways and the conventional ways, and it also is used. We cannot say, okay, we don't want to check BMIs anymore, but definitely we need to be mindful that there might be other ways. And then the Edmonton obesity staging is another good way to see whether you are at stage 0, 1, 2, 3, 4. Because what it helps is, next, if you have the staging, then you know when to intervene, how to intervene, right? Okay, so if you have no risk factors, then of course lifestyle modification, you can continue. But then if you have risk factors, you might add on the behavioral. If you have a disease with comorbidity, the tertiary prevention level, then you have to do medical. So that way, the EOSS works better because it gives you also where you are, what are the treatment modules you can use, and what is the complication you expect. Next. You can also, however, do it with the BMI, right? Like if the BMI is a little on the high side, 30 to 35, you can say, okay, you might need some behavioral therapy, you might need some medication, but if your BMI is more than 40, you definitely might need surgery. So that is something that you can do even with the BMI. But when you are staging it, it is also easier because you know that where the patient is heading when it comes to their health. Thank you. And so before saying that, I just wanted to add that, we also check our waist-hip ratio. And we will talk about it in the next few slides, but we also say that it is about visceral fat, so which I'll talk about after this. I have these two slides because sometimes, we have tools, but we don't use them. I think in South Asia, because people pay out of their pockets and there's not a lot of insurance. So when patients are asked to see a dietitian, they feel like, oh, you're not doing your job, you're giving your work to somebody else, I have to pay more. But actually, we need to have a teamwork where we encourage our patients to see the dietitians and the nutritionists, because there's a lot of data and a lot of talks we can talk about. We can talk about the microbiomes, we can talk about intuitive eating, the plate method, the dietary supplements. Next, which for a physician, as before the meeting, a doctor was saying that I've been so busy with my clinics that I have not been able to join the meetings. Exactly. So without the teamwork, I think it is very difficult for one person to do everything. And then we know how important prebiotics, probiotics, the microbiome are there. We need to explain, and especially in the local food. Like most people think it's only in the curd, but in Nepal, we also ferment our greens. So that can be a good way of probiotics. And then I know in the Middle East, I think they ferment their beans or their olives or some pickles, so without salt. So that can be a good source. And this only this would be good for a nutritionist and then dietitian to explain. And next few slides, we can go faster. And then how energy dense food is, what is low energy dense. Next, how to substitute food, what is low calorie, what is high calorie, how much fiber you need, like all that can be explained by a dietitian and a nutritionist. Next. So importance of fiber cannot be underestimated in weight management, right? We have to tell them, this much fiber you need, how much fiber you're taking. So somebody to calculate that. Next. Because we have seen that with dietary fiber, the weight management actually gets better. So I think what in these last 2-3 slides I was trying to say is we need teamwork. Next. So in general, we as physicians, as doctors, as endos, we can tell them, okay, have a small portion of food, control your portions, eat regularly, eat smaller plates, divide the plate into 4, get an app. These are the general we can tell. But for details, we'll need an expert. Next. And also to re-evaluate it, because I realized a lot of patients actually think they're eating less, but less is more. And then no obesity treatment management can be done without exercise, right? So whenever we are talking about exercise, we have to understand that any amount of physical exercise is good. It doesn't have to be cardio, it doesn't have to be a lot, but any kind of exercise has to be incorporated. Next. And there are so many of our elderly, right, who say, I have knee pain, I have back pain, I'm too old, I have osteoarthritis, I can't do it. But what we can tell them is not every exercise or not every time we are talking about exercise, it's about running, swimming, Sometimes I just tell them, move your eyes, sit at home and do the reverse namaste. Anything to exercise, start with your flexibility. Then you do some balance. Then you can go for aerobic. And of course, the goal is to do resistance training, because we know that sarcopenic obesity is becoming an issue, which we're going to talk next in the few slides. And for that, it is very important that our elderlies actually do resistance training. So sarcopenic obesity is becoming one of the biggest problems in South Asia. We know that we had visceral obesity, right? So we are like the way we used to say for Cushing's, lemon on a matchstick, right? So we have obesity, we have visceral obesity, and very few muscles. And this actually is now leading to a lot of, next, the muscle loss combined with obesity is actually leading to sarcopenic obesity, which has high cardiovascular risk. Next, when we are always telling patients that why I'm so thin and why we are so young, and I'm still getting a heart disease, I'm not even that obese, but that can be because of the combination of obesity and your less muscles, your lean muscles going down, which is a higher risk for, of course, osteoporosis, falls, fractures, and coronary heart disease. Next. And also the other thing is that in Nepal, it's not so much, but I know that India, Bangladesh, I think not even in Pakistan, but they do have a lot of people who don't eat a lot of protein, eggs, or any kind of meat items. Protein is actually considered bad for health. They think that they're vegetarian, it's a religious thing, and that is why also they're malnourished in protein, and that leads to this exaggerated sarcopenic obesity. And as I was saying, that we are lucky to be in an era where anti-obesity medications are there, because before there was just like metformin, topiramate, and maybe bupropion, and these were not the most effective and not without a lot of side effects. There was always something or the other associated. Some drugs are coming in, some drugs are leaving the market, but now we have these GLP-1s, the dual agonists, the SGLT2s, which are very safe, good for the heart, good for the kidney, and obviously good for obesity management. Next. So, and the future for weight loss drugs is, I think, if I've written the slide today, in a week, it's going to be old news, because there's so many drugs that are actually coming into research. Next. Yeah, like I said, it's a lot of drugs that are there in the pipeline, and we'll see more and more of it. Next. There has to be like one session, one day only for future loss drugs, like the GLP-1s. But I think most of our countries, especially I'm always envious of Bangladesh, that they even have tirzepatide, which is generic. But at least we know that now sema is available. It is cheaper than it used to be. And we have both the single and the dual agonists. And that is helping a lot with our, weight loss, helping our patients for weight loss, which we were hitting a wall with. Next. And this is one of the topics that, at least, like I said, I work in a private corporate hospital, and whenever we are talking about surgical procedures, patients don't like it. They feel that when we tell them to not to eat, they feel there's, you get these defensive reactions. I don't eat, like I eat minimum, and we understand that. Then we tell them take medication. They're like, oh, medications, but why not? And we're like, no, like you need medications, because these are you're not achieving your goal. And then when you tell them you need surgery, they really, really don't feel good about it. They're like, what? But believe me, there are patients who will benefit only with surgical procedures. And we know that even after 5 to 10 years, 1/3 of these patients may fail. So we have to offer, as guardians, as doctors, as well-wishers for them, it is that whether they like it or not, whether it's pleasant to the use or not, we have to offer surgical procedures to patients who actually will benefit from it. Next. So to conclude my slides, very simply, because I've talked a lot, that obesity is now recognized as a chronic disease with serious complications, right? So we have to manage obesity not at point one, but in a holistic approach. We have to have a teamwork, surgical, the dietitian, the nutritionist, the physiotherapist, the psychiatrist, the counselors, everybody. And of course, we need the general public, we need all the doctors. And I'm so glad that today this medical association of 19 countries has come together, because we have to create awareness among both the physicians and the patients with the general public to curb this global rise. Thank you so much. And I hope that those who have not visited Nepal can come to Nepal. It's a beautiful country with the Himalayas, and it'll be always good to host you. Thank you so much.
Thank you so much, Dr.
Good
Dina.
morning.
It was a wonderful conversation. I welcome Dr. Chong, our chairman. Okay, we are here.
Dr. Chong.
Chong is back. Okay.
Chong is back. Dr. Chong is back.
Thank you.
So-
Thank you, Dr. Shrestha. I also have a Nepalese patient called Shrestha. Same surname. So I'm familiar with the name. He's
And
been
Dr.
my
Chong,
patient for-
Shrestha is a very common surname in Kathmandu.
Oh, is
Yes.
it? Is it right?
It's like Khan for Pakistan or Agarwal for India, I guess.
It's like
It's like a Wong
Chong
in
in
China,
China.
or Lee.
Oh, yes.
it's like Chong and Lee in China, you know.
Nahi, what is its meaning? Dr. Chon, what is its meaning?
Shrestha means, if you go literally, the best.
Oh,
But
oh.
that's a common caste. You know,
Oh.
but the literal meaning is, when you say Shrestha, that means something good.
Yes, yes. That is why he is handsome.
Thank you so much.
Thank you, Dr. Shrestha. But very interesting topic, because this is something we struggle with every day. I mean, all of us struggle with every day as clinicians. I think it's a very, very difficult topic. The truth is actually the human being needs very little fuel. We are cavemen, right? We kill an animal, we eat for the next 24, 48 hours. After that, we can't put it in the fridge, so we have to finish eating it. Then the next kill could be 1 week later, and then along the way, we're eating stuff off the trees and the ground and all that. So the reality is that we're fighting against evolutionary instincts that have kept us alive. And we are in a feast famine. We're built for feast famine, but unfortunately today we live in a land of plenty. So I always like to tell my patients that if you look at your blood sugar is 100 milligram per deciliter, it's actually 1 gram per liter. So 5 liters of blood, most of us have 5 liters of blood, that's 5 grams of sugar. 5 grams of sugar in your blood actually powers your whole body, your heart, your lung, everything. You can even run a marathon on 5 grams. So, and when we eat white rice in Singapore, it's 60 grams per bowl, 60 grams to 75 grams of sugar per bowl of white rice. So these are all the problems I deal with every day, trying to explain to patients that we actually need very, very little fuel to survive. Our bodies are incredibly efficient engines. Yeah.
And the thing is that we are lacking in nutrition. Even when there's a feast now, there's a famine. If you check for vitamin D, if you check for iron deficiency, these days we see a lot of magnesium deficiency. So we are eating food, but not nutritionally sound food, like tasty, good, calorie rich, but not necessarily something that is nutritious.
Yeah, I remember reading somewhere that, for example, in the United States, children drank fruit juice, fruit juice in a carton with corn syrup. So 1 liter, they'll drink 1 liter of fruit juice and then they'll be full because it's full of calories. But actually they have malnutrition.
Yeah, exactly.
It's quite sad to see that the quality of food. I mean, honestly, whatever country it is, it's actually expensive to eat food that you purchase from the fresh market and cook yourself. It's actually an expensive thing, you see. And fast foods and hawker foods, we call it in Singapore, for example, are actually much cheaper, but it's all carbs and flavors. So,
Yes,
so
that's why in one of the slides I had seen, one of the most powerful drivers of obesity is low socioeconomic. Because to tell people to eat healthy is expensive. And in South India, that becomes a problem.
Yeah. So unfortunately, like even for example, the crazy president of the United States tells everybody to eat fast food. It's like
French fries.
unbelievable, it's unbelievable. I mean,
For
so
him, it might be a lesser sin than waging wars. So if war for him is fine, then I think eating McDonald's is like
well, like speechless. But the beauty is all the GLP-1s have really been revolutionary move in this area. And of course, the costs are sky high. Hopefully, with loss of patents and all that, these prices will come down, and it'll be more available to the world, to the globe. But these are very interesting group of drugs. I think we should have you back here for another session on just talking about these drugs. I mean, because there's so much coming out of research on and data on these drugs that are so fascinating, right? it's not just the weight loss, it's a lot of other things it's doing to the body. And the fact they found it in a lizard in a Mexican desert is amazing. I mean, the biodiversity, story, it's quite amazing. So I look forward if you can do a session with us on the GLP, the GIPs and all that, and all the latest stuff. That'll be most fascinating, yeah. But challenging. This is a huge problem, whether is it in any country. I think it's a challenging problem. Any questions from the floor?
I think
Dina, I wanted to ask you a small question. There's been people have been promoting high protein diet as weight control, maybe anti-diabetic, anti-thyroid and all. There have been physicians who have been doing. What's your say on that?
I mean, definitely, I think what you're talking about, high protein diet is, so we want appropriate diet, right? So something around 1.2 grams per weight is like fine. But because most of Nepal or like I was saying, India, actually are living on 0.4 to 0.6, the data is, right? So when we say high protein diet, we are not expecting 2 or 3. We're saying at least if it appropriate diet is 0.9 to 1.1. So we are like, okay, you can go up to 1.2, 1.3, decrease your carbs, have good quality of fat, and increase your fiber. Because in the end, you do need calories and you do need protein. So you don't want to increase a lot of fat. You want to decrease your carbs. So of course, we want a little bit of extra protein, but not, I don't think so the recommendation is more than 1.5 gram per kilogram.
Because there have been physicians who have been promoting that, high protein diet and intermittent fastings and all these things.
I have to say, I'm a big fan of intermittent fasting myself.
Yeah.
So I believe in that.
I understand intermittent fasting has some science, but high protein diet strictly in the Nepali context, I think there have been physicians in Kathmandu who have been promoting that. In fact, we had few issues in council also. So what's your say as?
I think what was the problem is the keto diet, the high fat diet, the keto diet where people died, unfortunately. And, people are some of our physicians who were behind bars for the right reason. But that was because there was keto diet, which is a high fat diet. That was that without monitoring, without with comorbidities can be very, very lethal. And I think that is one thing that we are not promoting. But I know that in the Middle East, for children, they still believe in keto diet, but it has to be very regulated, very much, there's some science behind it, but it has to be used with a lot of caution. And for people who are very, the safety has to be a priority there.
Okay.
I think intermittent, if I'm not mistaken, Dr. Shrestha, but intermittent fasting, if during that 8 hours that you eat, you must still watch your sugar spikes, right? Because if you still allow your insulin to jack up, you're back to square one.
That is one of the most common myths, or I think what the misunderstanding is that when you're doing intermittent fasting, people think that in that time where you can eat, you can eat everything and anything.
Yeah.
And you still want to eat healthy. You still don't want to eat spikes. You still don't want to, carb load yourself. But if you eat within a time range and you give your body that 16 hours or 18 hours of fasting, definitely we've seen enough studies to prove, like I said, patients who are not, we're not expecting people with insulin and on basal bolus to go on an intermittent fasting. But definitely it does work in a certain subset of people. I really feel bad for Dr. Akhtar Hussain, whose hands are up. Please.
Thank you, Dan. Thank you so much, Dr. Chon, your input on the obesity. The problem is we know we have all the evidence that carbohydrate and carbs are easily, cheaply available around the world. And we got evidence based that these are the food causing so much cost for the public sector, private sector. Why we as a profession and as an organization recommend that sugar must be banned in the kitchen, or we can put the price, the government must put the price so high, just like cigarette prices are going up, but the people are not stopping smoking cigarette. So they keep smoking and the price is going up and up. Same thing with the Coca-Colas and things like that. So I think it's a time as a professional organization, we recommend strongly that this costing so much billions and billions complication of the patients, and price must go up, and the kitchen must not have a salt and sugar. So we change our dietary habit, eating habit. Maybe it will be solve some problem. That's how I'm thinking. Thank you.
Yeah, so put
In
sugar
Nepal,
as
we
a
have
sin
promoted.
tax.
Can,
I think in
can I
Nepal, we
ask
have
question?
started sugar and related drink tax, and we have requested government to increase it, like
I think
tobacco
in
tax.
Singapore we have sugar tax, right?
Yes, we've started a sugar tax.
Yeah, I
In Nepal
heard.
also it is started.
Sort of sugar tax, and not quite sort of, but there's now a restriction on the amount of sugar that can be put into, for example, a drink and so on. There's some restriction. Yeah.
Can I ask question?
I met the sugar tax in India, but in India we call it as anything which is in the refined form of any product is should be banned or should not be taken. Like a sugar comes from sugar cane, so everything like there's a jaggery, there's all other materials. Even if you want to have sugar, go for a non-refined form rather than having a refined form. Even for the oil, even for whatever food you're having, try to eat it raw the way it came from the nature.
True.
So to clarify what we've done in Singapore, I just wanted to update everybody. We don't actually have a tax, but we now rank anything with sugar is ranked from A to D.
Okay.
A, B, C, D. So there's a ranking. And yeah, and you have to avoid the D. D is bad. D is bad. Yeah, D is a fail.
Yeah, but would that ranking is only for the mental satisfaction, but people still have it.
Yeah, unfortunately, and also our hawker centers, they have actually made every hawker stall in a hawker center, because our hawker centers in Singapore are quite interesting. They are actually subsidized by the government. The rentals are subsidized, you see, so there's actually some subsidy. So they have made every stall holder come up with one healthy option, one dish. There must be one healthy option dish. So they're doing things like that, but it's not easy. It's not easy.
So nobody is having the steamed tofu.
Yeah, it's actually.
Dr. Chong,
Yeah. Yes. Yes, Dr. Pukhari.
thank you so much. Thank you so much. First of all, thank you so much for such a nice presentation, and it is the need of the day. I have one question. One question is that what do you think? What is the simplest way? Because most of our public, they do not listen this webinar that we are discussing. And majority of the people who are suffering with obesity or diabetes, they are the public. What do you think, keeping in mind the atmosphere of Nepal, India, Pakistan, how can we convince our people not to take so much carb or not to soak in fat? Because it is the addiction. Otherwise, if we can leave it, it is not difficult to leave these things. I am taking the tea without sugar. What is the simplest way? How can we convince our people?
I think like somebody even in the group has written, Angelique has written that carbs are addicted, right? So,
Yes, addict. Yeah, this is just addiction. Yes.
Because it does hit your hedonic centers, and it does release dopamine. It does make you feel happy. Any one of us and every one of us, whoever's had carbs, knows the pleasure we get from it, right? So in a place where we are stressed out, we are worried, we are anything, sometimes just food becomes our way, and our social culture is also made in that way. I think the one thing I tell people now, because I believe in cognitive behavioral therapy, and I feel that just telling them doesn't work, is be mindful of what you're eating. When you eat, when you look at the plate, if you can just tell yourself, okay, I'm eating this, 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 and that makes them think, because sometimes it's all a reflex. You have 4 chapatis, or you have 3 bowls of rice, you have your red meat, you have your beef, you have a kebab. You're not thinking, you're just eating, talking, having a conversation. And dinner and lunch is our family times. So I tell them nowadays, be mindful of what you're eating. Say to yourself, I'm eating this, and this is what I'm doing. And sometimes that helps them curb, okay, I'm eating, this is my 4th chapati that's going in, or, this is the 2nd bowl of mutton I've asked my wife to bring in. So sometimes mindful eating kind of is one of the small steps in curbing your appetite and, realizing that what you're doing.
I think my message is that if we reduce our diet and we skip our one meal, either lunch or either dinner, I think it is better to keep you healthy. Like I myself, I'm a 70-year-old without living hypertension and diabetes. I take only one meal in a day.
That is why I was saying that intermittent fast. You're on, sir, we can't hear you. Please.
Dr. Bukhari was saying, what is more important, to have 2 meals a day and
yes,
or split that meal into the multiple meal?
Yes, sir. In my experience, I am a pathologist. Basically, what is the thing in Pakistan? I think most of the heart attack people, they are at night and they are overeaten, and when they sleep early after taking the dinner, they have chances when they are over the 40, over the 50, over the 60. Like what I do in the I think, and in the morning I take a cup of tea, this one, and a small yogurt, and then nothing. Then I will take my lunch. That is about 2 to 3 p.m. I'll take, and my word, 1 and 2 bread, yani chapati, that is called in Pakistan. That is, and then I take meat, or then I take rice, then everything. Then I do not take anything till the next morning. But I can take even a cup of tea when I'm in a meeting, or when I'm in anything. So meal I have skipped, because when we advise this intermittent dieting, most of our patient reverse the sugar. And I think Dr. Dana, you will endorse this thing that this sugar can be reversed, even obesity can be reversed, if we take care of our fat along these things. Thank you so much.
Yes, exactly. So you know that in one of those long introductions of mine, endless, we are also part of the steering committee for the Co-Direct Nepal. So the Co-Direct that actually happened in UK, where diabetes went into remission with low-calorie diet, we are actually doing it in Nepal, and we have had success. We have had good success in the phase 1, where we have got diabetes remission in almost 30-40% people with calorie restriction, and now they're doing it in a larger scale. So I do believe in that. But as I said, this whole topic is about holistic approach. We cannot forget those people whose mothers, whose genetics, whose biologicals, who are on antidepressants, who have osteoarthritis, who have ulcers, So there will be a subset of patients where just this calorie restriction intermittent will not work. They will have to be taken to a psychologist. They'll have to be given some extra therapy. Some medications will be there. You're right. Maybe 30 to 60% of the patients will benefit from what we say. But what about the remaining percentage? So we have to keep in mind that, yes, most of us will benefit with that. But there are other people who might also need additional therapy and help. I agree. Thank you.
Any other questions on the floor? Dr. Chong, you were saying something.
No, it's okay. I mean, one of the issues, one of the issues, Dr. Shrestha, is that if I'm not mistaken, the problem is that when you start a diet today, for example, it actually takes a while for your insulin levels to come down. And that's actually one of the biggest problems we have, because the insulin takes about a couple of weeks for it to come down, to downregulate. I mean, that's why I find it's a big problem, because if they start a diet today, their sugar is low, but their insulin is still relatively high, and they have a lot of symptoms, and then they end up breaking the diet.
I mean, that is one of the most common things, right? When we say that, okay, eat less, exercise more, and the patient comes and says, I can't work, I can't function, I get these tremors, and I feel so hungry. And that's like, then I said, like any addictions, that is withdrawal. You're withdrawing to your thoughts, your good food. And what I do sometimes is, if they have a fancy purse or a fancy watch, I take it away from them. So I tell them, "Can you just give me your watch or your phone," and I put it in my tray, right? And they're like, I'm like, just imagine, I'm going to give it to you after 3 days. I'm not disturbing anything. How are you going to feel? And they're like, not good. I'm like, you won't be able to sleep. You'll keep thinking about it. And I'm like, how do you expect something that is biological affects you so much? And then something that you've been doing for the last 20, 40 decades, you suddenly don't eat your carbs, you're feeling fine. So I feel like you need to burn that. You have to learn to live with that feeling that you're not feeling good, you're shaking, but that is your body trying to now adapt to the new environment and the new system that you're building. And that always takes 6 months to 1 year, I think, at least, for you to, have a positive effect. It can't be like overnight. It can't be over a month.
Is that feeling of a shakiness and all those things that they feel, is that metabolic or is that dopamine?
It can be both, because see, if you have acanthosis nigricans, right? If you're severely insulin resistant, so you're right, you do have the insulin spikes. Even in the morning, it is there, and then the cortisol is working. So definitely, I would say it has to be both.
So it's a bit of like a hypoglycemia symptom, you think? Sort
Yeah,
of.
Yes.
Relative hypoglycemia, relative.
But they will never. Most people will never go below 60, and you cannot. So you have to tell them you want to live with the feeling.
Okay. Well, thank you very much. It's almost 1 o'clock already.
Yes.
We don't have any more questions. We thank Dr. Shrestha very much for her time.
Dr. Chong, there's a last question from Dr. Kaji. There's a last question from Dr. Kaji. So, is there any values in testing insulin levels? Quick test?
Yes. I feel that rather than insulin, C-peptide, we can test to see the amount of insulin resistance, or if they do have insulin. That is something we do. And I think it also encourages the patient to feel better, especially like Dr. was saying, that if you want to think about remission, then you want to check the C-peptide to see, you have good amount of insulin, and that is why you can be off medication. So that's something that I do when I'm trying to get off the medications.
Thank you, Dr. Shrestha, for that wonderful presentation and that little nice conversation and the beautiful picture of the Annapurna mountain range, which I recall fondly when I went to Pokhara.
Yeah.
And without much ado, thank you very much again. And we'll like to have you back here to discuss the GLP drugs, if possible. Maybe Saurabh can look into that. And thank you very much, President, for being here with us today as well. So, everybody have a good one and have a good weekend. And thank you very much, Dr. Shrestha. Thank you.
Bye-bye.
Thank you everyone for joining. Thank you,
Dina.
Dr. Dina, for wonderful presentation. And we will see you again next week. Thank you.
Bye.
Thank you, Dr. Dina.